Hello, this is Sonya Noor. I'm a vascular surgeon. I practice in Buffalo, New York. Reporting to you from CVC 2016. I have with me Dr. Winscott, who's in Mississippi. And we just got done on a session he moderated, which was a very interesting session, where we had a group of interventional cardiologists, vascular surgeons, and together we talked about atherectomy, some of the complications, some of the different maximizing outcomes, and the different devices. This is such a complex topic about when to use atherectomy, and that's often a question we get asked about it. So I'd like to know what your thoughts are on how you approach atherectomy and where do you think the future is?
Well, I think it was a very interesting session that we just finished, really highlighting the pros and cons of each of the atherectomy devices that are on the market currently, specifically in the CTO population, and looking at laser and directional atherectomy with both the Hawk device and the Pantheris device, as well as rotational and orbital atherectomy. I thought it was a very healthy debate regarding all the different devices. I think we really highlighted some of the devices really shine in certain lesion subsets, and some of the devices have maybe some more limitations than others. One thing I think was a common theme, especially on the complication avoidance section of the talks, was about distal embolization.
Right.
And I think that's really important when we talk about these complex lesions that we're treating. And a point that was made is it's not just the risk of if a embolus was to occur, but what is the risk of that embolus occurring in that patient that
Absolutely.
may have very limited runoff, critical limb tissue loss. So personally, I use a lot of directional atherectomy in my patient population. I've used all of the devices on the market, and for my very complex patient population with a lot of critical limb, I've just seen in my patients that the Turbo Hawk and Hawk 1 devices perform much better in my population than the other devices. But I use embolic protection on just about every single case because of the high incidence of embolization in my patients' lesion subsets, and also the risk of that embolization causing a major problem, because very few of my patients have 3-vessel runoff.
Sure.
So I thought that was a very healthy discussion, and a very common theme amongst very broad operators, both interventional cardiologists and vascular surgeons, of the importance of managing and preventing embolization.
Another question we talked about was, with all this calcium and different devices we can now use to debulk calcium, and then the role of drug coating or drug eluting technology, what do you think where is that going, and how do you think that's going to do?
I think we've got some early studies, preliminary studies, that demonstrate that I think there's a lot of benefit from debulking a calcified lesion prior to drug-coated balloon. You have increased drug uptake, you have better lumen gain acutely in your procedure. I think very calcified lesions that I deal with on a daily basis do not respond well to balloon angioplasty alone. They recoil, they dissect, and so they really require debulking. I think the definitive AR study looking at specifically Turbo Hawk debulking followed by DCB demonstrated there is definitely exponential benefit to using those two modalities together. We're actually involved in my institution with the reality trial, which moving forward is going to be looking at a prospective study looking at DCB following directional atherectomy and the 2-year patency of that. And what I've seen in my patient population now that I've had DCB on the shelf for about a year and a half is that our patency rates are definitely improved. We use directional atherectomy followed by DCB on a daily basis, and we've definitely seen a difference in our patient population. I think that's going to be reflected in the results of the reality study.
Well, we look forward to those results. Now tell me why CVC, and what do you think is good about it?
CVC is a great meeting. This is my 4th year been involved in this meeting. I've gotten to know Dr. Gulzar very well, and we've become great friends. It's really a unique meeting. I've now been able to work my way up to the leadership position in the meeting, and I think that the reason I targeted this meeting as the one I wanted to devote my time to is its uniqueness in that it obviously addresses both arterial and venous disease, but I'm mostly an endoarterial operator, and what I've seen is, just like this morning, is the topics were so narrow and the speakers on the topics were very dedicated to what they believed in and were very thorough in their talks. And so I get a lot out of it, even though I do almost exclusively endoarterial work in my practice. I still come to this meeting, I learn something every year. It's very well organized, and I love Chicago.
Well said. Thank you.